The posterior plating of the ankle fracture has been something that's gradually increased in popularity over the last couple of years, driven, I think, really by enthusiasm of foot and ankle surgeons. And you see in their meetings this being driven, I think, as the current gold standard technique. And like a lot of enthusiasms in orthopedics, it follows, I think, Scott's parabola, where you'll be familiar with this. It was published in the BMJ in 1986, I think. We start off with a promising idea, encouraging reports, it becomes standard treatment. And then doubts creep in, there's a widely publicized medical legal case, the technique falls into disuse, and the last one here is my favorite, very old surgeons amaze their juniors with rollicking stories of the good old days. And we've seen that come through again and again in orthopedics, haven't we? And the importance of posterior, of this really as applied to all orthopedic techniques is this. This is the 5th century Greek version of the Hippocratic Oath. And our first duty to our patients is primum non nocere, isn't it? Do no harm. And we mustn't get excited by these new developments and new techniques as they come through. When we think about posterior plating of the distal tibia, the first thing is that the patient usually has to go prone or into a sort of sloppy lateral position, which is a position that many of us are not familiar with when we come to fixing ankle fractures, and that immediately dials in a chance of confusion and error. The patient has to go, if they go prone, that positioning with the care of the tube also dials in a whole series of possible problems and errors that don't exist when the patient's just having their ankle fracture treated in the standard supine position. I think Mike asked me to give this talk, largely because of this horrendous case that my friend Mikko in Helsinki sent me just a little earlier in the year, which I think exemplifies some of the major problems with embarking on what is quite extensive surgery. So this was a 23-year-old fit and active lawyer, as it turns out, jogging on ice, who slipped and fell and broke her ankle and ended up with a trimalleolar fracture. And if you look closely at the posterior element of this, it's really quite a small little flake fragment at the back. The CT scan confirms it's not a major fragment. There's a little posterior subluxation of the talus, as you can see there, but of course the medial and lateral sides haven't been fixed yet. So that's maybe not as important as you might think. So they embarked upon surgery and with the gusto and enthusiasm put a massive locked plate at the back of the tibia there. And the articular reduction is really quite nice, I think. But in the post-operative period, the patient, like many of my patients, complained of severe unremitting pain and gradual increase in swelling in her foot. And they re-explored it. And as you might suspect, they found that the sural nerve had been involved in the closure of the wound at the back, and so they removed the offending suture, returned the patient to the ward, and then found that she continued to, we're missing a slide, continued to have severe unremitting pain, and the foot became progressively more dusky. So an angiogram was performed, showing that the entire vascular supply to the foot had been removed at the level of the dissection to put in that posterior plate. And although there was an attempt to reconstruct it with a reverse saphenous graft, the patient developed compartment syndrome, which then became an infected series of fasciotomies and a below-knee amputation. First, do no harm. Was that really worthwhile for that small posterior malleolar fragment? So, like Paul, I've looked through the evidence, and as he has very nicely summarized, the posterior malleus doesn't contribute to stability and isolation, and fragments of less than 40% don't change contact stresses in the remainder of the tibial plafond. And clinical studies show that isolated fractures generally do heal well, treated non-operatively, and that although outcome of a trimalleolar fracture is worse than the outcome of a bimalleolar fracture, because you've had a further injury to the tibial plafond, this is associated with ankle stability, not the fragment size or the operative treatment. And I think the only thing I'd suggest wasn't quite right was that paper by O'Connell, which suggested that posterior plating is better than anterior screws, used the AFOS to measure that. Only one domain showed any advantage for posterior plating. The other 5 domains showed an advantage with A to P screws, so they rather selectively reported their outcomes. So what do we do? So I think posterior plating, my own personal view, is it's perfectly reasonable in pilon fractures where you're having to reconstruct a much more difficult type of injury. But when it comes to ankle fractures, it's really only worthwhile, I think, when the mortise reduction isn't perfect after fixing both the medial and lateral sides, and in a patient where EP screws don't achieve adequate purchase. What have we done? Well, we've looked at our last 460 fibular nail fracture fixations over the, went through those in the last few weeks. They're mostly elderly patients, as you can imagine, and 1 in 3 of those had a identifiable posterior malleolar fracture on their admission x-rays. As you can imagine, most of them were fairly small, and only 1 in 6 of those fractures were fixed. So relatively small numbers as we get down to actually worth being fixed. And of those, only 1 was a posterior plate, and the rest of them are AP screws. So just in the last couple of minutes, I thought I'd just quickly run through what my technique is for those, because I think it's very straightforward and easy to achieve. Here's a typical patient, 68-year-old woman with ischemic heart disease, low energy fall, osteoporotic trimalleolar ankle fracture with some swelling and bruising and blisters. This is the setup, patient supine, their foot's there on a radiolucent block, so it's above the level of the other foot, so the eye can take a nice lateral picture. This is a different patient, so I did this just last week, but this is the position of the incision, followed by a blunt dissection with an artery clip, followed by the use of an instrument just to push that posterior malleolar fragment down and in, and then placement of screws from front to back through stab incisions. And that's how it looks on the II. Complete the procedure by fixing the lateral malleolus, and those are the small percutaneous incisions required for that procedure. Outcome, looking back through all those patients that we fixed with AP screws, we have had 1 failure. And this patient walked early on this fixation, and you can see it's failed and the posterior malleolus is subluxed up. So it's not 100% foolproof, but all the other ones have worked out and have gone onto union in their reduced position. So, to conclude, I think we have to be very careful in adopting new techniques and taking them up widely without critical thought. And this is a procedure that dials in a whole load of positional, anatomical, and fixation problems that we may not need to get into if we can use a simpler technique. Thanks very much.